Welcome to our Ensuring Effective Medical Care for Children with Hearing Loss webinar. This webinar is accessible with sign language interpreters and real-time captioning brought to you by a live captioner. To view the captions, you will need to click the caption button at the bottom of your screen, and then you can drag the captions around your screen to set the best view. My name is Dana Selznick, and I am the Director of Education and Family Programming at the Center for Hearing and Communication. For those of you who are new to CHC, we are a nonprofit center with 4 clinical departments consisting of audiology, communications, education, and emotional health and wellness. I am now excited to introduce you to my colleague, Michelle DeStefano, our Director of Audiology.
Good evening, everyone. Please join me in welcoming Dr. David R. Friedmann tonight. Dr. Friedmann is a neuro-otologist, cochlear implant surgeon, and research scientist at NYU Langone Medical Center. He performs ear surgery on children for hearing loss, chronic ear disease, and with tumors at the base of the skull. His research interests include cochlear implant outcomes in patients with residual hearing, single-sided deafness, music perception, and how we can improve the delivery of hearing care. His current research funding is from the National Institutes of Health. We look forward to hearing from you, Dr. Friedmann. Before we introduce him, I would just like to remind you if you have any questions tonight throughout the webinar, please put them in the Q&A, and we will have time at the end of the presentation to answer those questions. Now, please help me welcome Dr. David Friedmann.
Thanks so much, Dana. Michelle. It's really a pleasure to do this tonight. Just want to make sure that my slides are showing well. So yeah, we'd like to talk tonight about how we evaluate children with hearing loss. And I'll say as a sort of just at the start that I will not really be talking much about treatment at all, really talking about how we identify, investigate, and work up a child where hearing loss is suspected. And with that comes a few disclaimers. I should mention very clearly that I am not a geneticist. I work with some terrific ones, but I will try to distill some of these complex topics and really just to provide some background of what we can do to evaluate children who present with hearing loss, because there have been some real advances in the last few years, and we'll talk about some of those. I'll try to provide an update on some of the gene therapy approaches that are available as it relates to treating specifically children with hearing loss. And as a separate disclaimer, I'll mention that I am a proud part of the CHC team for a number of years now. And what that means is really fairly regular interactions with the audiologist with regards to patients that we may share. And I'll try to highlight in this conversation how a medical evaluation really does work to complement what goes on, the work that CHC does, for example, in terms of audiologic evaluations, and how we really make a team to come up with recommendations as it relates to how we manage and treat patients and make recommendations to families. So with that, hopefully you all know that hearing loss is really a pervasive issue, and in kids it can affect speech and language development as well as cognitive and educational outcomes. And when you look statistically speaking, hearing loss is among the most common congenital sensory impairments, so more common than issues with vision, for example. And while we often talk about this being about 1 in 500 babies are born with bilateral hearing loss, we know that the prevalence increases with age. And so when you start to look at kids getting into adolescence and even their teen years, that becomes even more common. So what do we mean by a medical evaluation? I mean, this really starts at birth. When a child is born in a hospital in the United States, there's what's a universal newborn hearing screening program in which your child will be evaluated for hearing. And this is a screening test that it's not intended to give sort of diagnostic information, but just to understand, do we need more testing or not? Is there a concern for hearing loss? And that's what comes out of that test. In the case of a child who does not pass their newborn hearing screening, and you may know that there's a whole bunch of other things that get tested for in addition to sorry, my slide's not projecting. So I apologize. Hang on one second. Are you seeing these now? I apologize. Okay, so what did you miss from the slides? Not much. I basically summarized this, but so as it relates to these disclosures, and we talked about the prevalence of hearing loss, and we were here talking about how we work up the evaluation for hearing. So after a child is screened for hearing loss, if there's concern for hearing loss, they may be referred to their pediatrician for those results to be followed up. That usually involves confirming the diagnosis, perhaps being able to identify the type of hearing loss, if any, and then moving on to thinking about causes. What's the responsible reason for this? Is there an etiology we can identify? And as we'll talk about, that's not always the case that you can identify such a cause. Sometimes hearing loss occurs with other medical issues that may be related, that may not be related, just sort of co-occurring. And so that's an opportunity to identify those. And then start to think about what appropriate treatments or rehabilitations are given the information that was identified. So I'm really not going to talk much about this, but I'd be remiss to not just mention that, we could give a whole nother talk on the diagnostic testing that goes on. But that in the hospital, there might be some sort of objective test that doesn't require participation of the child. That could be something like a auditory brainstem response, or commonly referred to as an ABR. And then as the child gets a little bit older, we're able to do behavioral testing. And that's what you might think of as a more typical hearing test, where there's different sort of age-appropriate techniques for doing that to understand the type of hearing loss that the child is experiencing. So what are those types? We know that you can have a conductive hearing loss, and you can think of that as potentially reversible causes related to the outer ear or the middle ear, as opposed to inner ear hearing loss, which we refer to as sensory neural hearing loss. And we'll talk mostly about that as it relates to the potential for congenital hearing loss or progressive hearing loss. And this can be related to a whole number of different issues, but oftentimes it relates to issues with the inner ear, within the cochlea. And we'll talk about some of the different causes, both genetic and post-infections, as well as how it can affect to different degrees of hearing loss. And it is also possible to have a mixture of the two, both the conductive and sensory neural parts. So, this is commonly a question that gets posed to me as a neurotologist. I'm seeing a family, and what is the cause of my child's hearing loss? Can we identify what's going on? And if you take all pediatric patients, and not specific by maybe when you're even identifying the child, about 20% are related to what we call environmental or acquired causes. And this could be any of a number of things: perinatal infections, sepsis after birth, serious cases of meningitis, persistent elevated bilirubin. This is not sort of the more common jaundice experience of a couple of days that a child might have and might require some blue light, but more serious levels of high levels of bilirubin can cause hearing loss. There's certain types of hearing loss associated with prematurity. And then there's medications that a child or mother might get that can put the child at risk for hearing loss from that cause. And then the other group is generally thought of as genetic, and we'll talk about sort of the different types of genetic hearing loss, but it may be hereditary, meaning that it was inherited from a parent, or it could be sporadic. It might be pre-programmed within the genes, but not inherited from a family member. And when we talk about genetic hearing loss, we usually differentiate isolated hearing loss when the child has hearing issues without other medical issues associated with it, or as part of a syndrome. And each of these can be inherited in different ways. And we'll talk a little bit about this just to give a flavor for it, but you may have heard of this before, sort of the idea of a dominant versus recessive gene. And there's also the possibility that it's on one of the sex chromosomes, the X or the Y. We call that sex-linked inheritance. And there's even a subset of hearing loss that can be inherited through what are called mitochondrial disorders, and that's even less common. So what are our investigative tools? So a family comes in and we're talking about how to investigate the cause of the hearing loss. Well, one is the family history. Is there a history of hearing loss on either side? It may not be the parents. It might be the parents' siblings or the child's aunts or uncles. It might be grandparents. You want to know about the birth history itself. What went on? Was the child born full term? Was there any complications or issues around the time of the birth? An exam is really important. So seeing the child and looking in their ears, looking at their really whole head and neck exam in particular, There's sometimes some clues that would suggest some syndromic causes. And then even from the hearing test, we can get some ideas about what might be going on medically. So there are certain patterns. You may have heard of a cookie bite being described as sort of a mid-frequency hearing loss, or low and high frequency patterns, flat patterns. These are all can be associated with particular causes. And so we might get an inkling about what's going on given the type of hearing loss pattern. And we talk about sort of more medical tools. We'll talk about three different topics in particular. One is imaging. The most common that we use to assess hearing loss, especially in kids, would be an MRI, magnetic resonance, or a CAT scan or a CT scan. We'll talk about CMV testing and what that involves, and how you can use that to help identify particular causes, and also talk more about genetic testing. So if we were to focus now on what we call congenital hearing loss. This is a child who's born with whatever the cause is for the hearing loss, and we try to break it down as to what could be causing that. It seems that about 5 to 20% of those cases are related to CMV or cytomegalovirus, which I'll talk about more in a moment. About 30 to 40%, depending on the studies you look at, will have some sort of inner ear or temporal bone findings that might explain the congenital hearing loss. And some of these categories overlap a bit because some of the inner ear structural conditions can also be related to a genetic cause, but about 50% of those congenital hearing loss cases will be related to genetics. So this is just sort of a nice chart that breaks some of this out. The numbers don't match up perfectly because sort of different studies will reflect different percentages, but if you have a child with congenital hearing loss, about half of those cases are environmental, half are genetic. And when we talk about environmental, by and large, we're talking about things that happen as an acquired case after birth, some of the medications we talked about, some infections, for example. And then genetic is generally broken down into this syndromic or non-syndromic cause, with non-syndromes being much more common. And some of the syndromes, we'll talk a little bit about these. For example, Pendred's, Usher syndrome, Waardenburg. These are some of the more common ones. And then we also could look at the onset. So as opposed to a congenital hearing loss may present at birth, and in which case it would be a prelingual hearing loss. But CMV, as an example, can also present from a congenital infection later in life, and we call that a delayed onset. So the child may not have any hearing loss detectable at birth, but then they subsequently develop that, and we relate it back based on the history or based on testing to that being related to CMV. The same can be true for milder forms of hearing loss, that it may not present at birth, but rather present after the child is potentially already developed some language skills, and we call that postlingual. So I want to focus on CMV for a few minutes. So CMV is probably getting a little bit more attention now with the recognition that it can be identified at birth. We're really talking here about congenital CMV infections. And we know that this is a very common virus in our society, and almost all of us have been exposed to it. And it's really reactivation of a latent infection that's believed to be the cause of congenital CMV, of a maternal infection being passed to their either their fetus or ultimately their child. It's the most common cause of acquired congenital hearing loss. And as I said before, it can actually present on neonatal screening, or it may not be identified until the child's a little bit older. And what's really important to understand about CMV is that it's not universally tested for. There's certain states that have trials and programs, and certain countries even around the world that have incorporated universal CMV testing, but it's not necessarily something that is done as a routine. There's some programs where they're doing it if a child demonstrates hearing loss in newborn hearing screening, they're then doing CMV testing. And the timing of this testing is critical. I'll talk more about that in a second. But it's worth noting that it's not the only type of infection that can cause hearing loss. And some of these other sort of classic, much less common issues such as toxoplasmosis, rubella, and then some postnatal infections I mentioned earlier, like meningitis, can also lead to hearing loss. So how do we test for CMV? And I mentioned before, it's not usually screened for at birth, but it could be. And if you are screening, the idea is to get those results within the first, or do the testing within the first 21 days of birth. And that's done because if you wait till after that time, it's hard to know if that was actually a congenital infection or an infection that the child just developed later in life, or once already born, just because this is such a common virus in our society. So you want to check within 21 days for if you're using urine, or you can use saliva. If there is an available dried blood spot, so dried blood spot is something that's often done as part of the as part of newborn screening for other types of issues, non-hearing related. Sometimes you can actually use that blood to do some of this testing for CMV. So that's sometimes an option, but the yield is not nearly as good as if you get the child's urine or blood in the or saliva in the first few weeks. So we mentioned that this CMV is really quite varied in terms of its presentation. It can be present immediately in terms of the hearing loss. It can be delayed. It can affect only one side. It can affect both ears. And it's also important to know that CMV can cause other neurologic issues. So you can have CMV-related hearing loss and no other sequelae or problems from CMV, or there can be quite significant neurologic issues. And in a number of cases, you can actually see some of these findings on imaging, and the radiologist might be able to mention, oh, this looks like CMV causing whatever's going on based on the imaging findings. What's really important also to know about CMV hearing loss is you can actually treat it. And so if detected early, we often treat with an antiviral medication, with something called ganciclovir, and there's really good data that this can prevent the hearing loss that might otherwise occur related to CMV. Radiologic imaging. So I mentioned that this can be, there's different modalities, there's CAT scans, there's MRIs. Generally, when we're imaging the ear in a child with hearing loss, we don't need contrast for any of these studies. And the types of things that we can see on a CT versus MRI are different. And so it's not universal as to which one is sort of the correct test. It's going to depend on what the concerns are, what the pattern of hearing loss is potentially. Is there a difference in the hearing between the two ears? When you look at large studies of kids with hearing loss, we see that about 25% have some sort of abnormality of their inner ear. And in some cases, we're looking at whether or not there's an auditory nerve. Is there a hearing nerve that connects the ear with the brain? And this is particularly relevant in patients with profound hearing loss. They've undergone an ABR or a hearing test, and we're not seeing any sign of even profound levels of hearing. And so we're wondering, is there actually a nerve intact that we can be confident is going to support something like a cochlear implant if that's being considered. And so MRIs can be particularly helpful for that. It's important to note that especially, it depends on the age of the child and whatnot, but we often will do MRIs with the help of pediatric anesthesia. So the child will get an IV and they'll be sedated. And this is important because these tests, can take up to 30 minutes, and we want to make sure that we get accurate images and really only have to do the study once. So having the help from anesthesia can make sure that we get good information with a single imaging study. This also serves as an important surgical guide or roadmap for abnormal anatomy if something like surgery is being considered to treat the hearing loss. So this is just an example from a CAT scan. You'll just get a sense of what the difference is between what these pictures look like. I'm not sure if you can see my arrow, but on the left picture, you can see what we call the internal auditory canal. This is where the nerves come from the brain towards to the cochlea and the labyrinth of the inner ear. And in this picture on the right side, you don't see that same formation of the canal. And what we learned is that you can see this really much better on an MRI scan. And if you look on the right image, you can see this nerve going towards the cochlea, and you don't see that in the image that's on the left side of the screen. So this is just one important way in which CT and MRI imaging is helpful for us. It can also identify other abnormalities of the inner ear. And so one common one, relatively common, is related to a progressive cause for hearing loss that can be seen either in isolation as part of a non-syndromic hearing loss, or it can also be seen as part of a syndrome. We call that Pendrad syndrome. And it's actually the most common syndromic cause of hearing loss. And you may hear this referred to, doctors, audiologists may refer to this as EVA or enlarged vestibular aqueduct. And that's an actual imaging finding that we can see even on a CT scan and gives us an idea about the cause for the hearing loss, gives us the ability to talk about the fact that this may be progressive and watching out for monitoring the hearing to look for any changes over time. So I'm going to embark now to touch base on some genetic topics and recognize that, like I said, these are complicated discussions, even among geneticists. But some basic patterns that we see are that we all get about 50% of our DNA or genes from each parent. You may know that genes encode proteins, and these proteins serve various vital functions. And what can happen is that genes can have mutations, essentially what we refer to, these are errors, which lead to errors in how the protein that it makes functions. Or in some cases, it may actually make no protein at all. And so these are some of the bases for how a specific genetic mutation can lead to problems. In this case, we're talking about hearing loss. We talk about hearing loss from a genetic standpoint. We differentiate between how the genes may be inherited, and dominant genes are expressed if only a single copy is inherited from either parent. And for recessive genes, the child needs to receive a mutated copy from each parent. If they receive only one copy, they may be a carrier and pass this copy on to their children, but they themselves are going to not express the mutation. They're going to be, we say, phenotypically more normal. So a classic example of this that we'll talk about is JGB2. So JGB2 is sometimes referred to as connexin 26. And what does JGB2 do? It makes a particular protein that's involved in regulating specifically some of the ions or the electrolytes between cells. It's the most common genetic cause of non-syndromic congenital hearing loss, and it's inherited in an autosomal recessive manner. So that means that the child has to receive a mutated copy from each parent. So if a child has two carrier parents that don't express the hearing loss, they have a 25% chance of having an affected child. So we also know that JGB2 has a lot of different potential mutations that can lead to different levels of hearing loss. And while it's the most common cause for severe to profound hearing loss, we can also see causes that lead to mild to moderate hearing loss in adolescence and may not even present until adolescence. So your child may have completely normal hearing until they are late adolescence and then identified with a mild to moderate hearing loss. And it may never get worse than that. The type of mutation really determines the severity of the loss. So you can imagine these cases with profound hearing loss, there may be less of the protein being produced, whereas in other cases, there may still be enough of it to give some level of function. So let's talk about genetic testing. So it's important to understand that there's just increasing numbers of genes all the time. There's constantly new research publications coming out identifying just from studies of various families genes that were previously unknown to relate to hearing loss. And when you do genetic testing for a child, it's not always the case that you're even going to come up with an answer, even if there is a genetic cause, and that's because there remains a lot that we don't know about what genes will cause hearing loss. That being said, we know a lot about different types of genetic hearing loss, and we know that about 70% of people who receive a diagnosis related to their hearing loss are going to have non-syndromic hearing loss, isolated hearing loss that's not associated with other medical issues, whereas 20 to 30% will be related to any of a number of syndromes, and I listed some of them here, Usher syndrome, Charge syndrome, Waardenburg's, for example. So what are the approaches when it relates to testing? It used to be that we would just target specific genes. So JGB2 being so common, you might just look for mutations in JGB2. And this has really evolved over time to much more comprehensive panels that have used the information that has been available about the different genes that cause hearing loss and will screen the child's DNA looking for those genes and for mutations specifically in those genes, so-called next generation sequencing. So I mentioned before, and I think it's important to remember that a child having a genetic form of hearing loss doesn't mean that it was inherited. It could have been a sporadic mutation. It might just be pre-programmed in their genes. And then when you look at the causes, most of these are going to be recessive causes, 80%, and there are some percentage that relate to these other forms of inheritance. And the only thing I want to add about this is that last point at the bottom is that there's a lot of work that goes into identifying whether or not a particular mutation is causing disease. And so if you ever receive one of these genetic reports or talk to a genetic counselor, there's a lot of language surrounding this is possibly, pathogenic or disease causing. This is probably benign or not disease causing, or in many cases, we don't know. It's sort of undetermined significance. And so that's why, these reports really need to be taken in context and reviewed with people with real expertise in terms of genetic counseling to either understand that we don't know exactly what the implications are, or to be able to determine exactly what results, what the meaning of these results are. I do want to just talk about some examples of hearing panels, and these are things that are now, most physicians or geneticists will consider ordering. Two highlighted here, and I have no personal connection with these, but they're some of the more prominent ones in the field. The University of Iowa has developed a panel called the Otoscope. Now they're now in version 9, just to show how this is sort of continually advancing. Cincinnati Children's has something called the Otoseek, which is another tool that they use to identify at least some of the major causes for hearing loss, and whether or not those are responsible for a given child's hearing loss. There's another resource that, again, I can't vouch for, but I think it's an interesting concept. One issue is that insurance doesn't always pay for genetic testing for kids as it relates to hearing loss. I think we're seeing more and more of insurances are, but this company, Resonate, is offering free genetic testing and counseling for people that meet certain criteria. So I took this off their website and I refer to their website there. But 40 years or younger, if you have bilateral moderate hearing loss, they will actually provide the testing for free and review it with you. And how do you do that? It's often with a blood test or a cheek swab, which will get that information. So just want to highlight sort of the variability in genes. So if you think about something like Usher syndrome, it's not just one gene and it's not just one mutation. You may have multiple different genes responsible for the different subtypes, for example, with Usher's. And this is true also for Waardenburg syndrome. And we know something about the disease progression or the disease type when we know the underlying genetic explanation. So you might know from some characteristic facial features, for example, that a child may have Waardenburg syndrome, but knowing some information about the genetics can help you understand what sort of course they might have or what other medical issues they may have. So something that's in the news a lot recently is related to gene therapy. And there are some ongoing gene therapy trials related to hearing loss that I wanted to just at least touch on. And this is, again, could sort of be a whole topic onto itself. But the idea is that there's multiple companies that have picked on a particular gene cause for hearing loss. It's called otoferlin or OTOF. And it's important to understand that this only represents about 2% of cases of congenital hearing loss in the United States. Two of the companies working in this space I highlighted here, Regeneron and Aquos. There's other companies in Asia that have ongoing trials enrolling patients. This requires a procedure. It gets performed in the operating room where there's it's a viral vector that's used to essentially provide the protein, provide the function that is being missed in these cases. And you might ask how this has turned out. And the answer is we don't know. It's really early in the process. It's certainly very exciting. There's some lay press articles that suggest some success. As of yet, my last checking, there's nothing published yet from any of these US trials, so nothing that we could point to as sort of peer-reviewed scientific literature as to how successful it is. It's unclear exactly what the outcomes that we could achieve, right? Is this going to mean that kids will have some access to sound? Is it going to be sufficient to support speech and language development? We really just don't know yet. And so some of the paradigms getting set up include maybe getting a cochlear implant on one side and gene therapy for the other side. There's questions about at what age would you do this ideally? How long can you wait to see if it's effective before you start to consider some of the more traditional treatments? So these are all open questions. And I'll just highlight again that the current trials going on in the US really are not widely applicable. They're only going to be appropriate for this 2% of cases of congenital hearing loss related to this particular gene. And so we talked about, JGB2 and others being much more common. And at this point, there is really not a gene therapy that's available to even consider for those types of hearing loss. So I want to try to wrap up just talking about other medical consultations that might be invoked. So audiologists will often refer to an otolaryngologist or an ENT. This might be a pediatric ENT or otologist who takes care of children. You might be suggested that your child see an ophthalmologist, and that can be both because of some conditions that may also cause visual issues, but also just to make sure that there's no other sensory issues. If a child has, hearing loss, we want to make sure that if they have a visual impairment as well, we can treat that. You may hear about children having tests of their urine, renal function, EKG, and this is because there are certain types of hearing loss, some of the syndromic forms that are associated with kidney issues and cardiac issues. And then certainly I work closely with my colleagues in pediatric infectious disease and pediatric neurology when we have children with congenital CMV infection, because we talked about how we can treat their CMV if we detect it early, and also to support other neurologic issues if they come up. And certainly genetics, right? This could be a genetic counselor, it could be a geneticist, a physician who specializes in genetics, depending on the nature of the problems and who you can see to sort of consider the genetic issues that go on. So we do know that a number of patients with hearing loss have other medical diagnoses. Approximately 40% of children may have some other identified issues. Some of these get diagnosed much later, once they start school. And this is certainly more common with the syndromic forms of hearing loss. And these are just some of the different types of things that we are looking out for. And so, we'll involve other types of specialists if there's concerns about any of these issues. So just to summarize, the type and degree of hearing loss, in addition to what's going on anatomically, medically, and developmentally, will determine the appropriate treatment. When we think about evaluations for kids with hearing loss, we really try to consider the whole child. And while the hearing results will drive the types of treatments we think about, we really look at this in the context of what else is going on with the child and what our expectations are for outcomes. We, as otolaryngologists and neurotologists, work closely with audiologists as a team to refine the diagnoses and make treatment recommendations. So we're constantly trading conversations about results of recent testing. If I see the genetic testing, I'm letting the audiologist know what we saw there and sort of what they can look out for. When they do a new evaluation as it relates to hearing or how a child's doing with hearing aids, they're communicating with us about that as well. And it's really important that we have these conversations because it allows us to align family expectations with what we expect in terms of potential outcomes for hearing improvement for their child. So with that, I will wrap up sort of the presentation portion. This is my email. You're welcome to reach out if there are questions or if anything was unclear. I apologize, given sort of the number of topics, it's just a lot of detail that I had to leave out to make this sort of coherent, but I hope it was that. And with that, I will turn back over to Dana and Michelle so we can have a further discussion. Thank you.
We just need to enable my video. Carolyn? There we go. Thank you, Dr. Friedman. I appreciate it. We've been very fortunate at CHC to be able to work with Dr. Friedman and other otologists to really work closely with our families and help gear them the best way. So I just want to remind everyone, if you have any questions, to put them in the Q&A or in the chat. I'm going to start with one question that came into the chat already, and we do have some that were submitted ahead of time as well. Can you determine if hearing loss was from a past viral infection, postnatal, and years later?
So we think about the viral causes, the most prominent I mentioned is CMV. And as I mentioned, because it's so ubiquitous, because it's so common in society, if you don't have that testing early on, it's hard to know that it was in fact related to that, unless you see what I mentioned in terms of, let's say, imaging findings. And there's some sort of classic imaging findings sometimes that you might see on a CAT scan that would suggest CMV, or certain patterns. I would say one-sided hearing loss with that was progressive. We start to think about CMV as one of the more common causes for that. But years later, it's impossible at this point to make a definitive diagnosis of a viral cause.
So I just want to check in because we got a very similar question saying, is there any option for testing in, say, a 2-year-old to determine if they're CMV? Like, will you see antibodies or anything? But I feel like that kind of answered the question, unless you want to expand on that.
Yeah, I mean, I would just add that, so like you said, if they have antibodies, that could be an infection that happened after birth and then wouldn't be at the same sort of risk for hearing loss. I mentioned the blood spot test because it's sort of an interesting idea. You have collecting blood at birth. Could you use that blood to run some tests to look for the DNA of the virus? And in fact, you can, just the yield for that is not that great. And so it's something that you can ask about if that's a consideration, running PCR on the dried blood spot. But the yield from it is unfortunately not nearly as high as if you had the urine or saliva from a newborn child.
One other question is genetic testing always something that's immediate or happens all the time when a child is diagnosed with hearing loss?
So you think that's asking, is genetic testing always done or is always?
Yeah, is it an automatic or is that something that's determined?
Yeah, I would say it's not, and it's not for a number of reasons. One is just the coverage issue. So, I always, at least in my practice, will always talk to families about it, and we'll talk about how it might inform our discussions depending on what the hearing testing is showing. It's certainly not immediate in the sense that it takes a while to get some of these tests back. I mentioned these two send out panels take a number of weeks, potentially close to a month, to get results from. It's certainly something you should ask about if you want to understand sort of what the options are. There sometimes can be long waits to see geneticists. So it's a process. I think the good news as it relates to that is it's unlikely that genetics is going to change anything that you do in the immediate term. It can be helpful information to have. It can help inform what to expect moving forward. It's rarely the case that, a genetic diagnosis that we don't already suspect it would really change our course.
So a similar question, not just for genetics, is imaging always needed? Do you always have to have an MRI or CAT scan when your child's diagnosed with a hearing loss?
I think clearly the answer is you don't always have to have it. I think that it should be part of the discussion. I would say that you should always see someone who can think about whether or not that's appropriate for your child. I think what we see sometimes is patients are referred to an audiologist and they're following with the audiologist for the hearing loss and they never even came across that discussion. Does imaging make sense? Is there suspicion for something based on the pattern of hearing loss? So I would say it's almost always a discussion, and there are definitely things that we may see that would make us recommend imaging. But especially if the hearing loss is symmetric, similar between both ears, in the mild to moderate range where a child's doing well with hearing aids, it's not necessarily the case that you have to do imaging.
Okay, and so we have another genetic testing question. If genetic testing was done at 10 to 12 years ago, do you recommend testing again?
Yeah, that's interesting. I mean, I think, as I alluded to with just the different versions of these panels, there's new publications and new information coming out all the time. And I don't know the specifics of the situation, but if it's, even it's just that the patient wants to, or the family wants to have a better understanding of what may have caused it, and previously the testing came up without a result, I think it's definitely a consideration to consider, repeating that testing given all the advances that we've made, not just in terms of the genes that we're aware of, but how that testing gets done. So, genetic testing is not genetic testing. Years ago, you might have just had screening for JGB2, and that was a form of genetic testing, but it certainly wasn't looking for all the other types of things that we're able to account for with more modern testing techniques.
So this was a question actually posed by a parent earlier today. If my wife and I were both tested and came up positive for a recessive hearing loss gene, does that mean our child needs to be tested too, or do we assume that's the cause?
So we're talking about a child born with hearing loss, two parents who have had maybe prenatal
recessive.
testing showing that they were carriers. Um, I think we from what we know epidemiologically, look at big studies, we know that especially in certain societies, certain ethnic groups, JGB2, which I alluded to, is the most common cause for that. Um, I guess, it sort of depends on the individual situation and how that information might be useful. So it's a little hard to comment on a specific situation, but um, it might be the case that it's related to that, and it certainly could also be unrelated to that. So I would say, it'd be hard to make that assumption just based on the carrier status of parents. In the case of dominance, right, if a parent expresses a particular type of hearing loss, or even just they themselves have the recessive condition, you might feel more comfortable that if a child is born to them with hearing loss, then that's the cause, right? But in the case of you don't have that history, it can be hard to make that assumption.
So here's another question. If my sister just had twins, one failed her hearing test, my sister was assured not to worry. It's common and will possibly go away. Should the baby be tested even if the hospital didn't recommend it?
So there is a relatively high rate of false positives from newborn hearing screening, and that's by design. The goal of the screening programs is not to miss a child with hearing loss. And so there's a number of things that can go on that can cause a child to have a failed screen in the hospital. And so I'm not sure what the recommendation was that's being described, but certainly I would say those should be followed up on. You should follow up and talk to the pediatrician, and you should see probably somebody that can repeat that testing potentially within the first, a week or two later. And you would do that just to make sure that that was in fact a false positive, something like, for example, wax in the ear, or certain types of conditions during pregnancy and labor can lead to fluid in the ear. And those things can certainly cause a child to fail a hearing screening test, but not actually have hearing loss. And those are things that can be clarified. We didn't talk a lot about sort of infectious causes of hearing loss, right? But otitis media is super common. Kids having fluid behind the eardrums, and I think about, that your child's brain doesn't know the difference if their hearing loss is from fluid or if it's from a genetic cause. And so whatever the cause is, you want to try to treat the hearing loss, whether that means, they need antibiotics for infections, chronic infections, or potentially placing tubes, whatever the issue. But we want to be aggressive, especially during that sort of critical period of language development, to make sure that we're treating whatever the cause of hearing loss is. So I definitely would follow up on a test that suggested that there might be a hearing loss.
And just from an audiological perspective, it's actually state law in New York State that if you do not pass your newborn hearing screening, you have to have a follow-up. And if you don't pass the follow-up, you have to have a diagnostic ABR test. So the hospital has to report in some way. So yes, you definitely have to have at least a repeat screening. Here's another question. Is a CAT scan better to do than an MRI, or should my child get both?
I think it's important to understand what the differences are, and to ask your doctor or your child's doctor why they might be choosing one or the other. There's certainly not a better or worse one. I would say that more often, in my practice, our approach is to order an MRI when we can, as opposed to a CT scan. Now, the trade-off there is an MRI takes longer to do, to actually acquire the images, but doesn't have any radiation, any ionizing radiation. The dose of radiation from a CAT scan is quite low, but we try to minimize that, especially when we're talking about exposure for kids. So one reason we prefer MRI is the resolution in terms of looking at things like the nerve. We're able to see the anatomy in terms of the inner ear quite well, although maybe not quite as well as on a CAT scan, which shows bone better. And we're avoiding the radiation that comes with the CAT scan. There are times where, depending on the finding of one study, we might suggest the other study. So if there's concern, for example, the child had a CAT scan and now we're concerned about the cochlear nerve not being there, we'll probably get an MRI as well. And alternatively, if we see something, that we could better see in a CAT scan. So there's definitely going to be cases where child get both, but I would say majority of children that I see for hearing loss these days will get an MRI and will not need a CT scan as well.
So if an MRI or CT scan suggests no or limited nerve, or they say they can't visualize the nerve, does that mean a CI is not appropriate, a cochlear implant?
Yeah, it's a great question. So it's important to understand a few things about that. One is we look at cochlear nerve, I'll call it no cochlear nerve deficiency, as a sort of a spectrum. And it can be everything from a smaller nerve to no visualized nerve. We know that we look at this in the context of what someone like our audiologist will tell us as it relates to is there responses to sound. So we certainly are discouraged if we're not seeing a nerve on the imaging, but sometimes we don't see a nerve, and the audiologists are able to do really confirmatory testing that looks like there is sound getting through on that side, and so that would support the idea that we can still offer that child a cochlear implant. And I would say even in the extreme case where there's no responses on the audiometric testing and we're not seeing a clear nerve, as long as the cochlea itself appears to be well formed, and as long as everybody's sort of on the same page about an understanding that we're not sure if there is, in fact, a nerve that will carry the information, we will often try it. And we've certainly had a number of cases over the years where we do see benefit even without a clearly visualized nerve. This is particularly for kids with bilateral hearing loss in both ears I'm talking about, not really for the one-sided condition. And I'd be remiss as a part of the NYU team to not mention that this is actually part of our protocol when we think about a whole nother approach to childhood hearing loss, which are auditory brainstem implants or ABIs. We consider ABIs in children who don't have cochlear nerves only after they have not gotten benefit from a cochlear implant. So even in those cases, we will try a cochlear implant before we go down the road of considering something like a brainstem implant to provide some hearing.
So this is more about genetic testing. Do genetic results tell me if my child's hearing loss will get worse?
I think that is certainly the type of information that you could learn from genetic testing. It just depends on the type of hearing loss, the type of mutation even. So that is an appropriate kind of question to ask. If you have a child who, they don't have severe to profound hearing loss, but they have some degree of hearing loss, knowing the gene, potentially from the imaging I mentioned, if you saw, for example, EVA, you might anticipate the potential for progression. And there's other types of hearing loss that are expected to be quite stable. And so you could potentially get the information from that testing that, the expectation from what we know of this particular genetic hearing loss is that it will stay as it is. So yes, that is the kind of information we can get from genetic testing, although we can't always get that information.
So we have another question. Have you ever heard of hearing loss caused by viral encephalitis, but hearing loss shows up several years later? Can nerve damage be from an infection ever be reversed or regenerated?
There's certainly viral causes for hearing loss. And, encephalitis just means an inflammation or infection of the surroundings of the brain. And so, yes, that can cause hearing loss. Certainly meningitis, which is a bacterial infection of the brain, can cause hearing loss. Most of those that I can think of are not years later. They could be a little bit delayed, but not, months later, but not usually years later. And generally speaking, if there's inner ear hearing loss or sensory neural hearing loss, whatever the cause, at this point in time, it cannot be reversed or regenerated. I mentioned the early treatment of CMV with antivirals. That was big news when that was first identified, that we could actually stop progression of hearing loss in those kids. But I'm not aware of any approach right now that exists to actually reverse inner ear hearing loss.
So this is a little bit different because we didn't really talk about this, but my child has microtia atresia. Does repair surgery mean she won't need a hearing aid?
Microtia atresia definitely fits into the pediatric hearing loss. And I had a little line about that, but it's fair to say I did skip over that a bit. So atresia
You had quite a bit to cover. It's okay.
Yes. So oral atresia, just to say, can also have a genetic component, has been linked to a number of genes. And in terms of management, right? So from a hearing standpoint, we generally talk about some sort of bone conduction device. The problem with oral atresia in general is that the canal itself is not open, so sound can't get in through the normal pathway. But for many cases of oral atresia, the inner ear is relatively normally formed, and the inner ear function is good. So the first question is the inner ear functioning normally? And that's something that I would be investigating in collaboration with our audiology colleagues to check, is the inner ear okay? And if it is, then you're doing something to try to address the hearing. And there's two general approaches for oral atresia, either a bone conduction device, and that can be something usually worn behind the ear to conduct sound through the bone to get into the inner ear. And in some cases, if patients are good candidates for this, and this really depends on the imaging findings, we potentially can do a procedure called a canalplasty or atresioplasty to open the ear canal and potentially place an eardrum if they don't have one, and help with the hearing that way. It's a complicated topic and not the most straightforward surgery. Bone conduction devices offer the most reliable hearing outcome for children with oral atresia. But there are sometimes cases where we can do procedures to open the canal, and that can be a successful way to help with hearing, potentially without the need for a hearing aid. But a vast majority of children with oral atresia are best served with bone conduction devices.
Here's another one. Thank you for being here. I don't often hear much about hearing aid varieties and model selection. Perhaps not your specialty, but is there a range of hearing aids, and is there an innovation here pushing technology forward?
Well, I might lean on you, Michelle, for
I was
some
gonna
help with
say,
that one.
it is.
But I mean, certainly we know that there's different types of hearing loss that are going to suggest the type of hearing aid that's going to be most appropriate. And when patients ask me this question, because they often do, maybe more so in adults, but also sometimes with kids, I'll say that, this is a discussion with the audiologist in terms of what the level of hearing loss is and what's going to be the most appropriate to fit that hearing loss. But I'm sure you have something to add to that.
Yeah, I would say for pediatrics, it's really, you're looking to be geared towards a pediatric hearing aid, a pediatric friendly hearing aid, one that works with an FM system or remote microphone, one that has enough flexibility for as your child is growing. So in the beginning, you don't want a lot of automatic technology, but you want to be able to enable that as they get older. And so there are limited hearing aids for pediatrics versus adults. For adults, we often try several different hearing aids and come up with the conclusion. But for pediatrics, there's really mostly hearing aids that are really going to work for a child. And that's what we're looking for, which is flexibility and helping them in the classroom setting and learning speech and language. As far as technology changes, technology in hearing aids changes constantly. Now artificial intelligence has entered some hearing aids as well. The thing to remember is for pediatrics for children, we're often shutting off a lot of that automatic because we want their brain to learn how to filter noise and process. But yes, technology changes faster than annually. It's always changing. And we often say the best hearing aid is the one that works for your child, the one that they're getting the input they need, the one that they're getting the access they need, and that's been verified to get the answer. I do want to point out before we get to another question, one of the things that I thought was really important that Dr. Friedmann says is that you go to a pediatric otologist or ENT. It is very different to see a pediatric otologist or a pediatric audiologist as opposed to someone who just does general ear, nose, and throat, because they really have a knowledge base that is far beyond just seeing an adult and taking, dealing with adult issues. So I appreciate you saying that, Dr. Friedmann.
If you don't mind, I'll add one thing to that, which is that it's not always so clear, it's not universal, unfortunately. Different hospital systems have different models for this. Neurootology, as part of their board certification, does include pediatric and adult care. Pediatric otolaryngologists have a distinct set of skills, and all sort of obviously overlaps as well. So not all neurotologists see kids, but almost all neurotologists, depending on their training, certification, will have pediatric expertise, even if they don't quote themselves as sort of pediatric neurologists.
There's another question. My daughter was diagnosed last year when she was 10, and she now wears hearing aids. How often does she need to be seen as a follow-up visit if she seems to be doing well with the
How old is this child?
10.
I think there's probably different routines based on how long they've been followed and how stable things are. Potentially if you had things like imaging and you use some more information about the cause, that might help you understand how often they should be followed up. I mean, I think at that age, our routine would be on the order of 6 months for hearing testing. Does that sound right to you, Michelle?
Yep.
Yeah. So definitely be following them. And we know that there's certain types of these hearing losses that will stay stable for a long time and others that we almost anticipate to progress at some point. And so sometimes things like genetic information or imaging findings can help, anticipate that.
Yeah, the only other thing I would say is if it's a newly diagnosed hearing loss at 10, sometimes you see a little more often in the beginning until you're trying to figure out what's going on and the path it might take. But then usually it's every 6 months and then annually. And what about for otology? Do they go back as needed or annually?
Yeah, it's a good question. I mean, I don't think there's any hard and fast rules, and again, sort of depends on the context. I would say probably once a year would be sufficient, and then if you have that collaboration with an audiologist, they're going to let us know if there's a change, right? So if you're doing that every 6 month hearing test, and all of a sudden there's a change in 1 year, then probably you'd be seen sooner. But I think otherwise, probably once a year is appropriate.
Okay, I don't see any other questions. I want to thank you, Dr. Friedmann, for being with us tonight. I know it was a lot of information that was out there, and you tried to condense as much as possible to cover everything. Genetics alone could be one whole webinar. So I truly appreciate it. If you have any other questions at all, you definitely can reach out to Dr. Friedmann, myself, or Dana. We've put the contact information in the chat, and we will also have a slide up for that so that you can get the information to reach out if you have any other follow-up questions. Thank you again, and thank you all for joining us tonight. We appreciate you giving us your time.